which was one of the hardest things for us to establish the first couple of years, is we would have people come, they would listen, but trying to get them to that point of feeling safe enough that they can drive the questions instead of it always coming from us. Because we had a few at the beginning where we thought great projects started rolling, and after about a year they were tanking, and then the people would go, oh, that was never going to work. And we go, well, that would have been really cool to hear about a year ago. So now we've gotten it to the point where the people really do participate and give us their ideas, and they drive what we do.
Yeah,
but
again,
that takes time. It takes trust.
It takes time and trust. And again, not everybody's going to be at the same. It's just personality type. Some people don't want to be as involved, but they want to be there and be able to give some feedback. So we have, again, people along that continuum. So what do we do as a network? So we have certain focus areas. One is education. That was one of the ones, had to be there, it was needed, it came up as a priority, and it's our give back. That's one of the ways we can help. Advocacy, helping people self-advocate, connecting them to resources that help them advocate, or we are advocates out in the community. Sharing information. You know, Pat was mentioning with all those partners, when someone says, I've got this problem, well, this partner, you know, this group probably could help you. Let's connect you up with them. And research. I mean, we're definitely there to do research. It is what Pat and I do. We want this increased quality of life and participation, and we want the sustainability. So we talked about that. You cannot live and die by the grant.
And it's interesting because, and we'll talk about a little more about the research side, people sometimes think about research in a bad way. Oh, you're coming in, you're taking some data and you're leaving. But from the clinical side, we want to do evidence-based practice. What is the most effective way for us to do treatment? What is the most effective way to do stuff? That's research questions.
And the hope that we are actually going to make impacts fairly quickly, not this way down the line sort of thing.
So in order to do that, you have to ask questions, which is research. And part of what we're going to talk about later on is the fact that what we do is demystify the concept of research.
So we'll talk about each of these areas a little bit. So with education, we've done educational videos. So again, when we got the additional funding, we got a website. We had a website put together actually early on, but with the extra money, we had people that could actually do some fun and fancy things with it. So there's videos, there is examples of transfers from wheelchairs to tractors. I work with AgriBility, and so we have a lot of people that are interested in that, how to get on their zero-turn mower. So we do some videos of that kind of thing. We have testimonials. We have people from with spinal cord injury talking about their experience, and we get hits from all over the world for that to watch those.
And some of the things about the videos, we've also used the education from providing an educational format, but it's allowed our partners to be part of it. And I've utilized the PT students at UK, and so they learned about their partners, so it gave them a better feeling of actually working with these folks. So it's making them better clinicians.
So that comes up.
No, so sorry.
Don't steal my thunder.
I'm sorry.
All right.
As you can tell, we'll get into this.
One of the other things we've done, we missed 1 year, but there's been 7 this year, 7 large meetings where we usually have 200 people that come to the conference, and they're wonderful. Again, same woman does our food. One of the things, the philosophy of the group, it is not like we do a conference for clinicians and a conference for people living in the community. It is a mixed group. The presentations are geared towards a variety of audience. We wanted everyone in the same room, again, so they're communicating. But that's been really very popular, people coming in from across the country to be speakers. We will be doing it again this fall. The KARRN members are very involved in this. They have strong opinions on what the topic should be, potential speakers. So this is one where they get very, very involved. And
we've been lucky that we offer CEUs for it. So we have clinicians of every make and model. They come in and they get CEUs for it, as well as we use it as an opportunity for the physical therapy students and the OT students to do it. Plus, we almost always have panel discussions where we have our community people then come up and say, okay, you've heard about this. here's our reality. And it really has shaped the way a lot of our students then start to, when they're going back out, they're going, oh, I remember I heard this at the conference, and now I now have a better understanding of their experience and what I need to do as an advocate.
So here's an example of products that the PT students did in partnership with the network. This is pretty early on. They developed one was, and this came from our group saying, look, traveling is a nightmare. We need some help. Or going to a park, I have no idea where I should go. I get there and all of a sudden I can't get in, can't get out of the parking lot. So the students worked with our community group and developed these brochures. So one is, traveling tips. So what do you ask? Who do you want to talk to before if you call a hotel, motel? Because if you call and they say, and you ask, is it accessible? They will tell you yes. And they will probably mean ADA accessible, if you're lucky. But that is not the same if you're in a wheelchair. That doesn't mean everything's accessible. I mean, people had horror stories of what that meant when they got to their room, actually. So what to ask? But it's also useful for the management of hotels. What is it that they're looking for? What do you need to be aware of? Then the students went to the parks and did accessibility assessments of them, and came up with a nice table that's, it's not slamming anybody, but it's showing, oh, this is accessible. This is, which parts of certain parks, and it helps you make a decision of where you would want to go. So in terms of research, Pat is going to talk about more recent, what's going on kind of right now. But in the past, what we've done when we got that extra money, we did the exact same study that we did with spinal cord injury. We did one with stroke and TBI, so the qualitative in the community, what's going on, what are your supports and barriers. And then we developed something called Research 101. So Pat was talking about demystifying research. This was, how simple can we make this and have it still be useful? And it came out fairly well. I think it's been used in a number of ways. And it is the idea of what is research? It's a question. Everyone can come up with a question. Everyone has a question. And we can help you then guide how to get the answers to that question through different methods or whatever. But don't be afraid. It doesn't have to be you're with a beaker in a laboratory. Research looks varied.
And my 5-year-old son asked enough questions in one day to have multiple PhDs. I mean, it truly can be that simple.
And then Pat also has spent a great deal of time, starting pretty early on in this, developing the Kentucky Stroke Database. I don't know if you want to add details on that.
Yeah, well, and it's the stroke registry, and it's in collaboration with Dr. Mike Dobbs, who is the head of neurology, or was the head of neurology. He's now taken on a significantly larger role through UK Healthcare, in which we now have, all of the data. If someone comes into UK, we know everything about them, so that we can really get down to figuring out, why do some people do well? Why don't they do well? The whole idea is Dr. Dobbs is also the head of the Kentucky Stroke Network, so all of the hospitals in Kentucky part of the stroke network. And now we're in the process of working through all the legal side of it to start to capture the data from the other partners. So we're working with Norton Healthcare in Louisville to pull it in. So as of right now, we have over 8,000 people their data on. The moment we bring in Norton, it doubles that size. So it allows us to ask very distinct questions. And the registry is actually built on 2 different levels. It's developed to do research questions, but we also have it developed where we have dashboards, healthcare dashboards. So the healthcare team here on the stroke floor have the data, what is going on their floor, so we can say, are they getting screened for diabetes? Are they being screened for this? How are their outcomes doing? So we're using it to actually drive changes of acute healthcare, as well as being able to ask the questions from.
All right, then with advocacy, we were able to do some connection through the website. And when I was at Cardinal Hill, since a lot of the the people with spinal cord injury that were part of our network came from Cardinal Hill, and they were all saying they wanted to mentor and they wanted to give back. It's like, well, that's a no-brainer. We got some funding from the Christopher and Dana Reeve Foundation to develop a, they liked the Peer Alliance. They didn't like mentoring, didn't like the word, but so Cardinal Hill Peer Alliance program. So we were able to train, I think, about 12 people to be Alliance members, people that we could connect patients at Cardinal Hill with. The goal was to have them out in Eastern Kentucky in the community so that when they leave Cardinal Hill, there's somebody that lives a similar life in a similar context that could give them help, versus getting mentorship from someone who lives in Lexington when you're in a very rural community very far from Lexington. So it was wonderful. That's where some of this video posting on the website. So that is up and running to a certain point. At this point, Cardinal Hill's changed recently. It's changed ownership. So we're in the process of looking at that. I know the clinicians at Cardinal Hill really want that back, and I know that the mentors, I'll call them mentors, the Alliance members wanted that. You're out in the local community a lot, talking to groups, advocating for what we're doing for the people we work with. Accessibility is a huge thing. It comes up every time, and it's still a huge thing for our group. And it's something we focus on at different times, and we're trying to figure out where we're going to go with that. But advocating on wheelchair accessibility is a big component.
And we actually have I won't get to it today, we have a small pilot study working with our colleagues at HDI to do accessibility assessments within a couple of these smaller rural clinics.
Primary care
clinics, and to really explain accessibility. In fact, yesterday I was down in Columbia with our partners from the Kentucky Office of Rural Health, and I met with 4 directors from some of the local hospitals down there to begin to tell us about some of what we're doing. So we meet a lot with different groups from the state all the way down to Big Sandy Diabetes Coalition. I was out meeting with their director not that long ago.
And then the last item here is kind of the holy grail of a community network. We talked about shared leadership, and that's the end of the continuum. This is an offshoot that came off of KARRN. So it's connected to it, but it's its own entity, the Kentucky Congress in Spinal Cord Injury, and that was from our initial kind of group of people with spinal cord injury that have been so passionately involved, and they're like, you know what, we want to focus on spinal cord injury because we had broadened to other diagnoses, and they're still part of KARRN, but they really wanted to get onto the policy and advocacy, political side of spinal cord injury. So they've been doing annual conferences, and they've been making great headway with city government recently. We've just developed a restaurant accessibility checklist, and just some things that would be out in the community you could hand to the restaurant afterwards saying, you know, you had some weaknesses. Here are some things you might want to think about in terms of wheelchair accessibility in restaurants. So, I mean, that's kind of what you hope for. That's like your baby. They've taken off from the group and are the leaders of that. Sharing information, so we talked about the monthly meetings, using the ITV, using the database of resources, which is part of our website. So by county, it's hard to do, it's hard to keep up, but at least to give some people ideas of what's out there in those counties. And just be getting out and talking to people like we're doing today, whether it's at local, national, or international settings. So at this point, I'm going to let Pat go ahead and talk about what's kind of going on at the moment, some of the things that have merged from our network.
Well, I suppose we should also ask, are there any questions from what you've heard so far?
Anything related to developing?
Yes, sir.
Well, I've got a couple,
Okay.
actually, so stop me when I go too far. Just want to go back, a slide on strength and diversity. And when you show the agencies, it looks like it's a diversity of agencies that you're looking at. Just for clarification, that is, I mean,
No.
there'll be diverse peoples in that possibly.
Oh, yeah.
It was all agencies that were listed.
No, there was community base. There were the people living in the community with spinal cord injury, with stroke, with TBI. Caregivers, health. Well, the healthcare providers would be part of the organization, but caregivers were a big part. I don't know if it's up there. People, durable medical equipment people, again, that would be more of kind of an agency side. But no, the heartbeat of the group are the people living in the community. But we do have access to all these other great resources that are interested.
You know, from the state level with State Office of Voc Rehab, the traumatic brain injury, all the way down to the MS Society and the Army Wounded Warriors program.
Yeah, and that brings a lot in, but it's the agencies that are bringing everybody. Or I guess you're reaching out to actual individuals?
Oh, no. Yeah, it started with individuals, period.
Okay.
All we wanted when we started were people living in the community with whatever it was we were talking about, and their family or anyone else who is interested. We had individual physical therapists that have small clinics out there that wanted to be part of this. You know, they don't have a lot of support. They don't get all that extra training. They might not have all the fancy equipment. So it started with individuals, but once things start rolling, these other groups want to be involved.
Yeah, it started with us trying to link with a few groups, but then once we got going, people started to see us as the linking partner.
A lot of people want to be in the community, they just don't have the time or the ability to do that. So you do have to be careful because, like I said, I mean, they would love to connect with us just to kind of use our people, and we have to be very careful of that.
Yeah, we're very protective of our team and protective of the region that we have now adopted as the group we work with.
And in a similar way too, the slide, and I'm sure we're out in the communities and the counties, we hear this a lot. You know, we care for our own, and I hear that sometimes, but you know, so that's a strength, but I see this sometimes as a barrier because you almost have to understand who our own is. And what I find is usually it's the multi-generational families. So, you know, if newer folks are in the community, they may not be yet the own. And even with spinal cord injury, when we think about who is the own or their gaps, does a relationship of somebody with an injury like that then change in the community because our own were those who were able-bodied and running around and participating.
Oh, completely.
And so how do we understand our own?
That came from the community members.
Yeah. Oh, yeah. I hear it all.
Do I think that's a little wishful thinking? Yes. It's a stereotype of rural communities that they're tight-knit and they're extended generations living nearby, et cetera. And there is some of that. There definitely is some of that. But it is not everybody, and it's not what I would want to be counting on. And it's not enough. We have a lot of people here that don't have the proper support, and they know it, and they don't have that supposed safety net. But yeah, things change. So you get the spinal cord injury, and your support group may look very different, or your group, your friends, your social group, everything. And transportation is such a big deal in that area. So if you're not able to get around by vehicle for whatever reason, for whatever period of time, people get kind of cut out of the loop. And so it's in there, it's the way they view their culture, but I can't say that it would be what I would want to depend on.
Other questions?
You mentioned how important it was to find out who the real string pullers were in the community, you know, Mary Jane of the First Baptist or whatever it was. Did you have a method or some suggestions for people that might want to do that as to how to really find out who that is? You can't just roll down to Main Street and ask.
Well, no, the good thing for us is some of our founding members are from within the regions.
And they were the ones that were super motivated right from the beginning.
So
that's a good sign right there. That they're go-getter people that are out there trying to make a difference. So that was a good first sweep.
And that's what we use now is most of our projects utilize community health workers who are people, lay health workers who are from the community. They know the ins and outs. They are known. They're the people that are going to build that trust. But for our first 8 years of existence, we needed someone to help build trust for us. So we had our key stakeholders out there. Dr. Fran Feltner, who is the director for the Center for Excellence in Rural Health, based in Hazard, is one of our founding members. She is also the one who helped create Kentucky Home Place, which is the state's health navigator or community health worker program. She's from that area. Everybody knows her. She knows everybody. She knows everybody.
Knows her.
So it was our foot in the door until you could start to build trust. But we employ and we work with people from the community. We employ the people from the community in our projects, and that's how we start to get the buy-in. And it's also showing that we have that commitment to the region. It's not us just coming in. It's like, no, we're going to hire you folks. We're going to work. We're going to train you. And we're going to use you as our true partners out here. Yeah. Anything else?
Well, in terms of development, so I'm going to go with the money for a moment. It's just a question when you're talking about network, and I find a lot of times with I mean, I see the grants that you have, and you're talking about the brochures and stuff, and the videos sound fantastic. Obviously, that costs money.
Not much. Those were pretty shoestring. We didn't get fancy video.
But well, that's okay. That's there's money.
Yes.
But I oftentimes find too when you start talking about a network. People, when I talk about networks, there's no money involved. We're talking about let's talk to each other.
Sharing.
So have you found, and again, I'm showing bias even as a government employee, that I find it's usually a lot of government people start anything by saying, well, who's paying for all this?
Oh, yeah.
And without saying the cost. So have you encountered that, even with all the agencies and the diversity, to get beyond it, there's just be here, be a person and be here?
No, I don't think we've heard that.
Yeah.
But, I can tell you. But I can tell you that there are a lot of people that think what we do is fabulous that haven't ponied up any money that potentially could have.
Yeah.
I mean, Pat can talk about that a little bit. I don't know if he's going to do that with some of these projects where it's like people are benefiting hugely, healthcare systems. And you're thinking, okay, you have some money that you could be helping us provide this versus us doing it free for you. So that comes up. And that's a skill. I mean, Pat is pounding on doors. We'll see what comes of it.
Yeah, and it's one where, I mean, we kind of learn as we go along on some of this, and usually it is, how are you going to sustain it? And whenever we start down a particular pathway, that is always something you have to think about, because the last thing you want to do is begin a project, and especially the direction we're going, where we're really trying to provide services in that, and then get 2 years in, and then you have to stop and you leave people out to dry. That is the worst, and we've heard those stories over and over and over again. That's bridges we've had to rebuild for 8 years because it's happened so many times out in Eastern Kentucky where people disappear. It's a one and done with the grant, and it's taken us time to build that trust.
Well, and that would be where the motivation has always been, well, there's got to be a cost here. I got to see money for my agency or something like that. And when it goes, I go. As opposed to someone who's still a network and there's value and still being at the table. I think sometimes we're better if we start with, well, there's no money.
Yeah, there's no money.
Talk about money, but let's make something good.
The goodness of your heart,
No, and it's fun where if you link into resources that already exist, like I said, we can get a lot done. We get phone calls saying, okay, we've had this individual who fell in this particular county, hurt their back. They need a specialized brace. Well, I can't just pick that thing off. I know it's not a Project CARAT in that. Can we find this? And then I'll throw it out to the network. And typically it's about 14 to 16 minutes. Someone will say, yes, in fact, we will send somebody down. One of the healthcare systems will say, we'll send someone down, we'll get them the brace, we will pay for it because it's part of their mission. I know the mission statements of a lot of our partners. I go, do you know what? By the way, this is part of your mission statement. You're supposed to be doing some sort of community outreach. So when you can go in there and you can kind of lay down in front of them that, you know what, you're supposed to be doing this anyway.
And look, we're giving you this great
opportunity. Giving you the opportunity. And do you know what? In fact, we will promote you through what we're doing. We'll give you credit for it. I'm more than willing to give people credit for doing this.
We're very careful of that.
Very, very about that. Do you know what? We've gotten a lot done without huge grants. Because as Beth has said, that if you hang your hat on federal grants, which is currently funding at the 10 percentile only.
So 10% of all applications.
That is and that's not going to change anytime soon. That being said, there are new organizations out there that are providing new opportunities for funding that we have positioned ourselves to be able to go after, that we could not have gone after 4 years ago.
And we've got some interesting partnerships that are developing amongst our partners. So I'm seeing here with emergency management, and we have, Pat has someone when he'll talk about Project CARAT, and she's just taken a half of a job. So now she's paid by both groups, and it helps us even more. I mean, it's just kind of interesting what creative partnerships can develop.
I think the biggest thing, we were very careful. There are some community, or there are participatory networks out there that are very, very siloed. They're like the physicians, or they're the dentists and that. We were very, very intentional about not putting parameters on ourselves or putting labels on ourselves. Quite frankly, we were in existence for about 3 to 4 years before I knew community-based participatory network was an actual term. I'm going like, wow, that's exactly who we are. Because the ironic thing, prior to working with Beth on the first project, is I'm a molecular neurobiologist by training. I'm a rat researcher before. Now all I do is community-based work.
I blew his mind when I said, you know what, we can do research that's just talking to people and be.
I mean, that is.
It was like a candy store.
Yeah, I'm going like, oh, now we get to play at many, many different levels. But it's one where opportunities are existing now that didn't exist, and you have to always be positioning ourselves. But no matter what, even if the grant money ran away, the partnership we have will continue to exist, and we'll still be able to do work. Because I leverage the PT students. They all have to do a research project, and they love doing projects in which at the end there's a product. They get out, they get to work with the people. So they have been wonderful to work with. So it's just knowing your resources and leveraging them. And then when you do get the grants, it allows you to move forward faster.
Yeah, you get to take big steps when you get the funding.
Yeah.
It helps.
Yeah, but when they go away, when you have the ebbs and flows, you're fine.
But I will say the time and effort to develop this network and the years we put into it pays off in funding. I mean, people see us. We exist. We didn't just come together for a week ago so we could apply for this grant. And people feel pretty secure providing money for our projects because we've been around, we've shown success in things. So it does build. I mean, the long-term effort is worth it in the end.
Last week I had a conference call with a team out of University of California, San Francisco, because one of the directors from NIH said, oh, you in California are running into some of these issues. You know what, there is a team in Kentucky that actually is doing a lot of this. Why don't you give them a call? So I talked to their entire research team, and it felt weird because I'm the one who did the majority of the speaking about what we do here, which is way beyond what they're currently doing in San Francisco. So we're going to have follow-up dialogue, but we're teaching them. So instead of us being, oh, you're in Kentucky, and being, oh, poor you, it's like, do you know what? We've positioned ourselves to say, yeah, do you know what? We've figured out how to get some of the stuff done with the partnerships, and the folks are starting to call us to figure out how they can do it in their communities, which has been kind of fun for us. So what I'm going to go through is a couple of examples that have been the natural evolution of what our group has been doing over the last couple of years. We have the Kentucky Care Coordination for Community Transition, KC3T. And that's how I'm going to say this, KC3T, because I am not going to rattle this whole thing off all the way. We have Project CARAT, which Walt is intimately involved with as its former director here. But that started as an initial partnership with us and the State Office of Folk Rehab, which has really gone on to expand out. And then I'm going to talk a little bit about our current PCORI funded grant, which is actually interesting, focused on how do you engage individuals in the community to be part of your team.
Research.
Research-wise, how do you research? We're being paid by the federal government to figure out how you actually engage people in the community to be part of asking relevant healthcare questions that will apply to them.
And they liked our group. There's not a lot of people out there working with spinal cord injury, stroke, traumatic brain injury in rural communities.
And the whole thought is, if you're working with the individuals, asking the relevant questions, that when you get the answers, you should be able to make changes to the system much quicker.